two options for treatment bradyarrhythmia. I think I will talk more about treatment AV block, and I will have own case presentations. So we have sometimes arrhythmias with reflex syncope. It's the patients, young generation patients without structural heart disease. Okay. So let me remind about ganglionic plexi, what we have in the heart. It means it's like parasympathetic and sympathetic nervous system, which affects heart and decrease heart rate or accelerate them. And we have several ganglionic plexi near the left and right atrium, as well as the coronary sinus in the heart, inside and in the entrance. And some of them are for more innervate the AV node, some of them more innervate the atrioventricular node, and they are mixed also. So what is the cardio-neuro-ablation? It's the irreversible ablation of parasympathetic nervous system, because inside the heart, endocardially, we have mainly parasympathetic innervation. That's why we need to denervate this innervation. First publications about cardio-neuro-ablations comes from Europace, Professor Pachon in 2005. So this method has about 18 years old history. 2005 published catheter ablation of severe neurally mediated reflex syncope, cardio-neuro-ablation, long-term results. So we have some maneuvers how we localize ganglionic plexi, but to be honest, now we are more and more using empirical anatomy-guided technique. There are red dots demonstrates ablations of GP, and it's left atrium with located GP, and this is the right atrium in ablation in superior vena cava or coronary sinus ostium. Some authors use monoatrial approach, monoatrial ablation, some of the biatrial ablation. So how we treat as a cardiologist reflex syncope? This is that I would say we have nothing for treatment, in terms of pills and drugs, for treatment options. First, it's like lifestyle modification for these patients, or you educate patient. You ask patient to just how to sit, how to, to drink more water, liquid and etc. But we have not like specific drugs to give the patient and his cure after reflex syncope. Okay, we have guidelines, and in guidelines, if your patient has an atrioventricular pacing is indicated in patients with sinus rhythm, with permanent or so-called paroxysmal third or second degree type 2 AV block, and it's 1C recommendation. So we have some recommendation in guidelines for the treatment in patient with syncope and AV block. I like this trial because it was like this. So 77 patients, more than 40 years old, 3 syncope in 2 years. It was the inclusion criteria. Asystole in the loop within implantable loop recorder. Asystole more than 3 seconds, or syncope, or just alone asystole more than 6 seconds. So in both group, patients were always implanted pacemaker, but in half of them, investigators just switch off the pacemaker. So patient has, maybe sometimes as in placebo, but investigators switch off. So in terms of, it was sensing only. In terms of both groups, patient Okay, when pacemaker was switched on, why they lose consequence? Everything is working. Patient has AV block. He has, okay, the pacemaker, but they still lose his consequence. About 20% of this patient has like these symptoms. So something was unclear. But let me remind that it was evidence only for patients under the 40 years old. What we have in guidelines about cardio-neuroablation, very weak, very not strong recommendations about this, and of course we need more trials, more investigations in this direction. This is the modulation of AV node in some, maybe we can discuss it after, in some of ganglionic zones, ablations, and you see how PR interval is shortening after ablation. And we see the several publications about treatment of AV blockade. Let me tell about extracardiac high-frequency vagal stimulation. For instance, we are performing it less and less because we have another criteria for choose the patients for cardio-neuroablation, but still we should know that we have some extravagal high-frequency pacing that we demonstrate after AV nodal block after pacing or sinoatrial block in these patients. And after ablation, this phenomenon should be gone. This is the navigation of these events, and very interesting trial for me when authors divided two groups. It's patient age up to 50 years and less 50 years. And what findings we have in terms of quality of life, quality improvement, and improvement of the symptoms. Younger generation, younger patients show the most benefits in terms of after atrial ganglion plexus ablation, more benefits from this in terms of fatigue, palpitation, and total benefit from those free from those symptoms demonstrated younger generation patients. So our indication criteria for cardio-neuroablation. It's a recurrent reflex syncope with cardio inhibition, symptomatic sinus bradycardia, and functional IV block. It's our first case report. 29 years old lady from another country came to our country to perform, and she was refused pacemaker because some of the colleagues offer this pacemaker. She has syncope, presyncope, and she was every day very symptomatic. She had, let's say, paroxysmal AV block in the ECG, or it's the Holter monitoring, yes. And we perform, first of all, we are starting always from EP study. And in EP study is the baseline, in general, Q interval and Q, every intervals are quite normal. So very important in our case, it's Wenkenbach point, you know. When we measure it before cardio-neuroablation, it was 480. And after performing cardio-neuroablation, acute Wenkenbach increase to 400 milliseconds. It was good sign for us. We perform so-called easy approach for this patient. We have two groups now. One hand side, we have groups when we perform left atrial ablation with the near the pulmonary veins plus coronary sinus, left and right. And in second arm, second group, we have a patient when we perform only coronary sinus ablation. It's very easy, I mean left and right side. And we demonstrate now the same results. We have good results in these patients. How we find this fragmented activity in the heart, half so-called or LAFEV potentials. We have filtered our in ablation catheter 300 hertz to 500 hertz. And when we find in this area anatomic approaches, for instance, but in this area these signs, we are ablate these signs. So follow up after 6 months. Any bradycardia in terms of AV block after ablation. This patient has 2 years follow-up and she feels very good and we are very happy. She is performing Holter monitoring every 3 months and we have very good follow-up. Second patient, the same story, quite similar history, loss of consequence, syncopes, 34 years old. The lady also with second degree AV block, and Wenkenbach point was 700 before cardioneuroablation, and after cardioneuroablation, acute Wenkenbach point was 500. It was for us good result. So the same strategy with the very interesting zones in near the coronary sinus. It's for electrophysiologists. This zone is posteroseptal area for electrophysiologists. So we bound this area and we found that our patient after 3 months follow-up has great PR or PQ interval and no presyncope episodes yet. So let me conclude. Cardioneuroablation is promising treatment options in patients with recurrent neurocardiogenic syncope, symptomatic bradycardia, and functional AV block. It's quite safe, has clear procedural point from my point of view, and a high rather clinical efficiency. So, and it's for sure the alternative for pacemaker implants, especially in young patients. Thank you very much for your attention.